to be around D. Yeah, so because the renal pelvis is lined by urothelial epithelium, and the renal tubules are located in either A and B. Yeah, so the renal cortex and the medulla. Okay, so this one I'm sure everyone knows by now, the glomerulus, what it looks like, and the renal tubules, okay, and the cortex, renal cortex, the renal capsule. Okay, one of the things that we look in a tumor is whether it has breached, it has invaded through the renal capsule. If it's confined to the renal capsule, then the prognosis is better. But once it invades through the renal capsule, then the prognosis is poorer. Okay. So this is the prostate. I just want to highlight the bilayer epithelium. Okay, you see the basal layer and the surface columnar epithelium. Okay, so the basal layer, these two layers are important because for us pathologists, we have to, when we are diagnosing cancer, the loss of the second layer is an important sign for cancer to be present. Okay, because only one of the epithelium will proliferate in cancer. Usually it is the columnar epithelium. Okay, but sometimes, rarely, we see the basal layer proliferating in cancer. So the absence of one of these layer, only one layer of epithelium is present in the glands, in the prostate, that points towards cancer of the prostate. Okay, so this is also an important sign. Okay, in urothelium, you see the layers of the urothelium is, this is like 1 or 3 layers maximum of cells. Okay, so in urothelial carcinoma, the layers are more than 7. Okay, so this is also an important feature that we look to. Okay, the urothelial epithelium. Okay, so we go to the case 1. A 60-year-old man presented with left-sided flank pain and hematuria. On examination, he has hypertension and left flank mass. Doctor also noted varicocele on his left testis. Renal ultrasound shows a 8 centimeters solid lesion in the left kidney. Chest X-ray showed a solitary nodule at his left lung. Lab investigation revealed polycythemia and hypercalcemia. Radical nephrectomy was performed, and tumor cells were present in the renal vein. Okay, so this patient has a lot of things going on. So what do you think why is he having hypertension? Anybody?
Paraneoplastic syndrome.
Okay, paraneoplastic syndrome. Okay, so hypertension is also a risk factor for this condition, kan? So hypertension is probably because of renin production in paraneoplastic syndrome by the tumor cells, or it can also be a risk factor for him. He has hypertension, then he has a higher risk for developing renal cell carcinoma. Okay, how does he develop varicocele? Anyone? Okay, so varicocele, so that's tomorrow's lecture. It's a dilatation of the venous plexus in the testis, and it often occurs in the left testis because the left testicular vein drains into the left renal vein, whereas the right testicular vein drains directly into the inferior vena cava. So this tumor, renal cell carcinoma, it has a tendency to invade a renal vein. Yeah? So this is a left-sided tumor. So when it invades through the left renal vein, it can block the drainage of the left testicular vein. So when you have the blockage, you can have dilatation of the veins in the testis, and that causes the varicocele. Okay, so this is anatomical and pathology correlation and we can ask this in the BAQ. Yeah? So polycythemia is also because of the paraneoplastic syndrome. Yeah? Okay, because this tumor can produce erythropoietin. Hypercalcemia is also can be because of the paraneoplastic syndrome because of the production of parathyroid related peptide. Can everyone hear me? Yeah.
Yes.
Yes.
Okay,
Yes.
all right. Okay, thank you. So the nodule in his lung is because of metastasis. Yeah,
Metastasis.
all right. Okay, so now we look at the tumor. Okay, this is the tumor grossly. So you can see there is areas of hemorrhage. So how do you describe this? Anyone wants to attempt?
Doctor, let me try.
Okay, good.
What if I said it is white yellow infiltrative lesion with ill-defined margin
Okay,
in the kidney with areas of hemorrhage?
okay, okay, right. So involving, you can say involving the renal cortex and the medulla, right? At the middle part of the kidney, right? This is the upper pole, this is the lower pole again. So it's not upper, not lower, it's the kind of like in the middle. Okay, so okay, that's good. So anyone wants to attempt the histologic feature? Okay, so you see this is the malignant cells. They are clear. Yeah, the cytoplasm is clear, and the nucleus is there's very mild atypia. And they are arranged in these groups and clusters surrounded by blood vessels. Yeah, so this is a very vascular tumor. So you can easily have hemorrhage like this. Okay, so these are clear cell carcinoma, or you can also say renal cell carcinoma, yeah, of the kidney. Okay, so what's the risk factor for this tumor? There's a lot. The most important one would be
Elder
age. Smoking. Yeah. Older age too is more to prostate cancer. So, but we also see this tumor in the people who are above 60. So, mechanism of spread of the tumor. It can spread to the veins. It can also spread to the lymph node, but usually it tends to spread via the hematogenous spread, and then it goes to the inferior vena cava, goes to the heart and to the lungs. Yeah, so the lung is one of the most common site for metastasis. So it tends to be hematogenous, but it can also spread through the lymphatic channel. Okay, so prognosis-wise, if you do not have metastasis, you have a very good prognosis, about 95%, 5-year survival rate. But if there is invasion and metastasis, then it goes down to 60% and lower. Yeah. So prognosis depends on where the stage of the tumor, and if it's confined to the kidney, there is very good prognosis with 95% 5-year survival. Okay, cell of origin, we've seen that is from the renal tubules, the renal tubular cells. You have many other types of renal carcinoma. We've seen the types that you can clear cell carcinoma, papillary carcinoma, chromophobe carcinoma. Yeah. Okay. So 3 most common renal cancers. The first one would be this one, renal cell carcinoma. The second one is
nephroblastoma.
Yep, we have nephroblastoma, Wilms tumor, and the third would be urothelial carcinoma. Yeah. The old name for it is transitional cell carcinoma, but now people are moving to call it urothelial carcinoma. Okay, so some of my notes maybe masih kata transitional cell carcinoma, but we've moved to urothelial carcinoma. Okay. Okay, so we go to case 2. 5-year-old boy presented with an asymptomatic unilateral palpable mass. Renal ultrasound shows a large solid lesion in the left kidney. Chest X-ray was also performed. Nephrectomy was performed and diagnosis of Wilms tumor was confirmed. He was started on chemotherapy post-operatively. So he had surgery and chemotherapy. Okay, so what's the most common presentation of this tumor? What the boy has, asymptomatic unilateral palpable mass. That's the most common presentation. Okay, so other presentation, this patient could have hypertension. This patient could have hematuria or abdominal pain. Okay. Why was chest X-ray performed? Again, just like the previous case, there's a risk for metastasis, and the lung is the most common site for metastasis, similar to the renal cell carcinoma. What are the syndromes associated with this tumor? There's a lot. Well, 3 syndromes. WAGR syndrome, which is Wilms, aniridia, genital abnormality, and retardation syndrome. Beckwith-Wiedemann syndrome and Danish-Drash syndrome. Okay, and the deletion that is associated with this is WT1 deletion on chromosome 11. Okay, what's the prognosis for this tumor? So if you do the combined therapy, chemotherapy and surgery, and also with or without radiotherapy, the prognosis is very good, is more than 90% after the combined therapy. Okay. Anyone wants to attempt this? So this is the tumor. Okay, so these are the malignant cells. So anyone wants to attempt? Okay, so cut section of the kidney shows grayish tumor, solid tumor, involving almost the entire kidney. Okay, so you can put negative ones. It's homogeneous grayish surface, no obvious necrosis or no obvious hemorrhage, probably here. Yeah, so but not obvious hemorrhage here. So histologically, can see some attempts to form glomerulus and the tubules, yeah, because these are the primitive cells. So these are the primitive cells, and you can describe this as small round blue cell tumor. Okay, so small round blue cell tumor with some formation of the glomerulus and the tubules. In some cases, you can even see cartilage, and you can even see muscles and all, because it can differentiate. These primitive cells can differentiate to many things. Okay. Now we go to case 3. Any questions from the two cases? It's quite straightforward. But if you have any questions, just stop me when you have any question, okay? So an 85-year-old man presents with back pain and urinary symptoms. So urinary symptoms, we'll talk about it a bit later. So rectal examination reveals irregular prostatic mass involving both lobes of the prostate. The prostatic specific antigen is elevated at 18. Yeah. So transrectal biopsy confirms adenocarcinoma of the prostate. Gleason score is 4+3. His bone scan confirms multiple bone metastasis. So describe the following pathophysiology in this man. He has back pain and urinary symptoms. Yeah. So back pain is because of
Tumor spread to the
tumor spread to the bone. Okay. So, and the urinary symptoms, what are the urinary symptoms in the first place?
frequency, urgency.
Yeah. Frequency, urgency,
dysuria.
Hematuria, dysuria. Okay. So, okay. So, where do you think? Rectal examination showed the prostate. There's a prostate mass involving both lobes of the prostate. So, if you do rectal examination and you feel the mass, which lobe is affected? Which part of the prostate? Yeah. Okay. So, it's the peripheral zone, yeah, that is affected. But if you have urinary symptoms, which area is affected?
Medial.
Central.
Yeah, okay, central part. Yeah, so it has spread from the peripheral to central. Okay, so because the usual area for cancer is the peripheral zone. Yeah, so that's why we can feel it with digital rectal examination. Okay, so we see that the PSA is 18. So how do we describe the significance of that result?
Suggest cancer.
How do we say? I mean, a patient comes to you with, and the PSA is 18. How would you tell? What would you tell this patient?
He is suspected with prostate cancer.
Okay. There is a risk. There is a high risk for this patient to have prostate cancer. Yeah. But it's not definite because only if your PSA rises to, I mean, the normal PSA is berapa?
For less than
Less
4.
than 4 kan? Less than 4. So if the PSA rises between 4 to 10, then what is your concern?
25% to diagnose with prostate cancer.
Berapa persen? 25%.
25.
25%. Okay. And if it's more than between 10 to 20, it is about, is it 100% patient will have cancer ataupun
No.
it's still a percentage?
Still percentage.
Yeah, it is about 50%. Some studies say 40%, some studies say 60%. So about 50%. So we have seen cases where patient has infection, yeah, and the PSA is more than 10, yeah, about this number 16, 15. So it's still, I mean, we still have to confirm by biopsy whether the patient has cancer or not. So you have to tell the patient that there is if you have PSA of between 4 to 10, then you have a 25% risk to have prostatic cancer. But if it's more than 10, yeah, between 10 to 20, then you have about 50% risk to have cancer. But you can still not have cancer. Okay, so it's not definite that the patient has cancer, even though the PSA is very high. So that's why they proceeded to biopsy, and that confirms the adenocarcinoma. Okay, so remember that the tumor markers, they are not absolute. Most of them are not absolute indicator for cancer. They just point that the patient has a higher risk to have cancer. So when we consult the patient, we have to be careful. Okay. So differentiate between PSA and hyperplasia in this case. I think we've covered some. I mean, PSA can still be elevated in hyperplasia, especially hyperplasia if you have inflammation and infection of the prostate. So when you have inflammation and infection, there's some damage to the prostatic cells, okay, and that can release the PSA even higher. Yeah, so and in some cases, if the tumor is very poorly differentiated, the PSA may not be high. Yeah, so even though the PSA is like it can be about 4 to 10 too, but it's just mildly elevated. But the patient may have a cancer that is poorly differentiated. So usually the doctor will advise for biopsy, yeah, in these cases. So what is the Gleason score and what's the significance? So this patient has 4 plus 3 Gleason score. So Gleason score is a score that we use to grade prostatic cancer. So the higher the number, the first one is the overall, the more significant or the majority of the glands, and the second number represents the minority of the cancer. Okay, so we usually see if many of the cancer shows well differentiated pattern, then we put a 3. Whereas if it's more poorly differentiated, less differentiated, then it's a 4 or a 5. Okay, so it depends on the differentiation of the cancer, because in prostate cancer you can have different types of differentiation of the cancer cells. So the higher the score, the poorer the prognosis. Okay. So the Gleason score signifies the prognosis, yeah, the grading of the tumor, and the higher the score, the poorer the prognosis. What are the risk factors for this malignancy?
Advancing age.
Yep, advancing age. This one is an important risk factor. So, any other things?
Family history.
Family history, yeah. Okay, family history, especially first degree relative, if the father or the brother has cancer. Anything else? Smoking, yes. For renal, for bladder, and for prostate, if you can put cigarette smoking as the risk factors. So just remember that for all the urinary whatever that goes into the urine, I think, because the carcinogen is excreted through the urine, yeah. So so it will be accumulating in either the kidney, the prostate, and the bladder. Okay. So what's the mode of spread and the prognosis of the tumor? So the tumor spreads through the blood vessel to the surrounding structures, such as the seminal vesicle or the bladder. And the prognosis is quite good. Yeah, is some people in Japan, they did autopsy. Well, Japanese memang dia suka buat autopsy on almost everybody. So they did an autopsy on people who are more than 80 years old. So almost all the patients had adenocarcinoma of the prostate, but they didn't die because of that. They died because of something else. Okay, like other comorbidities, but not because of prostate cancer. Most of them do not even know that they have prostate cancer. So the life expectancy is very good if it's localized, and it's the same as a man without prostate cancer, they say. But if there is metastasis, then the prognosis is quite poor. Okay, so I hope you can see the nodules here. So these are the cancer nodules, the yellowish nodules. So you can say that anyone wants to attempt? Any? So there are multiple yellowish, grayish nodules involving almost the entire prostate kan. So all the areas are involved here, and you can see, I mean, this is the urethra, so there is tumor nodules around the urethra, so that's why this patient had urinary symptoms. And you can see the cells, the malignant cells are forming glands. You see all the cells are the same. I mean, they're not, there is loss of the 2-layer normal prostate glands. It's all one type of cell proliferating, and you hardly see any of the stroma, the fibromuscular stroma. Okay. So the premalignant lesion in this case is prostatic intraepithelial neoplasia. So what are the different features of prostatic hyperplasia in this case? We said just now, I mean, prostatic hyperplasia, it is a hyperplasia of both the glandular component and the muscular component. So we expect to see, apart from proliferating glands, we expect to see also the fibromuscular stroma proliferation. So we don't see that in this picture. And we also expect to see normal type of prostatic glands with bilayer epithelial. So you have the basal layer epithelium, and then you have the columnar surface epithelium. So those are the major difference in the prostatic hyperplasia and prostatic adenocarcinoma. Okay, we go to case 4. 67-year-old man presented with painless hematuria for 2 weeks. Urine cytology showed presence of atypical cells. He underwent cystoscopy, which showed presence of multiple papillary structures, which was biopsied. Diagnosis of low-grade urothelial carcinoma was made, and his doctor advised him for close follow-up, as the tumor is known to recur and can affect multiple sites. So this is the usual workup for hematuria. Yeah, so the doctor may want to do urine cytology, and under the microscope we can see if it's a neoplastic lesion, we can see atypical cells. The cells are being shed off by the tumor. And then after the cytology, the doctor will proceed to cystoscopy. Okay, so the cell of origin in this diagnosis is the urothelium. What are the risk factors for this diagnosis?
Smoking.
Yeah, smoking again comes up. Okay, so remember that the carcinogen in cigarette smoking is being released into the urine somehow. What else?
Arsenic exposure.
Yeah, arsenic exposure. Okay, can have analgesic nephropathy. You've learned about analgesic nephropathy from the previous lectures, last week lectures.
Yes.
Okay, yeah. So when you combine Panadol and aspirin, yeah, so that can damage your kidney and also cause this tumor. Okay, so others, there's beer consumption, and there's a parasite that is associated with this tumor. What is it?
Schistosoma hematobium.
Yeah, schistosoma hematobium. Okay, so for this tumor, this is a low-grade urothelial carcinoma. What's the prognosis?
Good.
Good, yeah. So it's very good for this this case. It's about 98% of the patient has 10-year survival. But one thing is the tumor keep recurring. So the patient might have to be under close follow-up because the tumor tends to recur and the tumor can affect multiple sites. Yeah. So he has to be under close follow-up. So what other organs can be affected by this urothelial carcinoma? What other organs are lined by urothelium?
Does it mean the renal pelvis and ureter?
Yep, renal pelvis, ureter, and also, so
Urinary
you have the
bladder.
urinary bladder, and after that is the
Urethra.
urethra. Okay, there is another organ that can also have urothelial carcinoma, and it's the ovary.
Oh.
Because the epithelium is derived similarly. Dia dari apa uh, the epithelium is similar. So the epithelium in the ovary can differentiate into urothelium. Yeah, so we rarely get urothelial carcinoma, but you can have urothelial epithelium inside the ovary, and we've seen a few cases of urothelial carcinoma of the ovary. Okay, so we go to the other spectrum of this tumor. Another 70-year-old man presented with acute urinary retention after weeks of gross hematuria. Radiological findings revealed solid mass within the bladder. Radical cystectomy was performed. Diagnosed-grade urothelial carcinoma was made. Extensive areas of detrusor muscle invasion was noted. So what's the difference between the two? So this patient has high grade, the other patient has low grade urothelial carcinoma. Any difference in genetics?
In high grade, there is P53 mutation. In low grade, there is HRAS
Yeah.
oncogene mutation.
Yeah. So there's definitely a difference in genetics. Yeah. P53, some have retinoblastoma gene mutation. So we've heard of P53 dengan retinoblastoma in what osteosarcoma or other high grade tumors. But the low grade is dia ada FGFR3, HRAS. So the genetic mutation is not as as severe as the high grade ones. What about in treatment? So in low grade, dia ada papillary structure. So they just resect the papillary structure tu, and then that's it. Yeah. So but in this case, high grade, they can proceed to radical cystectomy. You mean the treatment is more aggressive in high grade urothelial carcinoma, especially in this case, there's the detrusor muscle invasion. So usually they will include kalau the urologist when they biopsy for urothelial carcinoma, they will include some detrusor muscle specimen that is near the cancer, because they want to know whether there is detrusor muscle invasion or not. Okay, the prognosis is definitely poorer for high grade high-grade urothelial carcinoma. So what's the significance of muscular invasion in this case? So the prognosis is poorer if there is the trusor muscle invasion. So there's 30% mortality rate if there is the trusor muscle invasion. So this is the, what structure is this? This is the bladder. And there's another organ here, which you will learn next week. Oh no, next week is Raya. So 3 weeks from now. This is the uterus. Tadi his bladder, tak. Dia tukarlah nanti. Ni perempuan ya. So this is a lady because she has this tumor. And it's from the bladder invading to the vagina. Okay. So you see the cells are quite pleomorphic. There's more than 7 layers of cells here. Okay. So there is the urothelial cells. There's with increased thickness of more than 7 layers of cells with pleomorphic nuclei, and there's also inflammatory cells here. Okay, so can we do a quick Kahoot?
Sure.
Okay, I have about 5 MCQ-like questions and 5 BAQ-like questions. Okay, so